But really what I wanted to do in the very beginning, before I kind of get to the core of the presentation, is I just wanted to take a moment to honor all the ways in which we use substances, and that substance use doesn't always mean addiction. And I think it's important to acknowledge this so that we can maintain and encourage a balance, and encourage people to make space to look at addictions and to look at illicit substance use from all different angles, and to not necessarily only look at it from a medicalized frame. So I just wanted to sort of put that out there. I think it's really important to acknowledge that when we're talking about addictions, we're really talking about a very small percent of the population. But knowing that the work that we do often feels like it's 100% of the population. But I think that this is really important for us to acknowledge. And so I really wanted to talk a little bit about sort of what's gone on right now. Everyone is very aware, I'm sure, that we're in the middle of a dual public health crisis. And so before COVID hit in March, and March, I don't know for you folks, but March feels like it was like 100 years ago. It feels like we've been doing this for 100 years. And I don't know other folks, but I can only see the first part of the screen. There's lots of people nodding their heads. And so, and it's landed hard on our services. It's landed hard on our different systems. And so pre-pandemic, I know that we were sort of starting to see progress. We weren't seeing, like, I mean, it wasn't magical. It was, we were still experiencing a significant loss, but we were seeing some really significant shifts. And some of those shifts were, we were seeing new relationships developed with novel take-home naloxone distribution sites. So for example, the DeRoche General Store gives out naloxone. So those are really neat sort of things that have been that were happening pre-pandemic. We are seeing more of our contracted substance use service providers consistently offering harm reduction supplies beyond take-home naloxone. We are and continue to see BC Housing supporting the development of overdose prevention services within residential settings. We are seeing addictions medicine becoming more accessible with new alternatives being made available. In 2019, we were seeing that overdose deaths were down by almost 600 people. Like, that's really significant. We are seeing increased and ongoing engagement with people's lived and living experience. And we've really seen, and we're continuing to see, it's not to say that this stuff isn't still happening. So we're continuing to see these like really incredible examples of active community engagement and lots of initiatives across Fraser Health. And so that was kind of what was going on pre-pandemic, and some of that work is still happening. But what we have seen is an impact from COVID that's been pretty significant. And so for us from a harm, and I suppose I should have introduced myself. I didn't do that. I went straight into my presentation. So I am a harm reduction coordinator for Fraser East for Fraser Health. My apologies. And so for the harm reduction world, what this really has meant, like how COVID has actually impacted us, is that we've really seen a sustained increase in overdose deaths across BC. I don't think that this is new news for folks. And it really has since the beginning of the pandemic. When the pandemic was declared, we're seeing a significant impact and increase in our overdose deaths. We're seeing really significant changes in our drug supply and our drug and increased toxicity. We have some really complex and confusing messages that we are continuing to sort of having to say, which is really like, don't use alone, but stay apart. Stay physically distanced, but don't be alone. And so that's a really hard thing for people to manage. We've had ongoing and continue to have, and I know that we're in the midst of this second wave, feels like a tsunami, but we're seeing really ongoing concerns with COVID exposure and overdose response, and lots of people questioning about what they're supposed to do and how they're supposed to respond. We're seeing a decrease in the utilization of overdose prevention services and safe consumption services, and we are seeing decreased access to harm reduction support services and other substance use support. So when we shift to only virtual, that makes it so that not everybody can access those services. And when we decrease connection with folks, like we're definitely seeing some impact from that. And we are seeing decreased hours and access to other vital social support services. What we used to have where people could drop in and access services, maybe we're not able to do that as much anymore, or the hours have been cut, or it just looks differently. And when things look different, it feels different. And what we've really, really seen, and this is something that I just really want to underscore, is we've really seen an unintentional decline in service provider focus on overdose prevention and harm reduction practices. It's hard to hold both and. So it's hard to focus on this global pandemic that's impacting the world and at the same time hold space for this very serious overdose crisis that we are in and that we've been in for almost 5 years. It was declared in April 2016. When April hits next year, it will be 5 years. And at some point, I don't know when we stop calling it a crisis and we call it something else, but I don't have the word for it. I've even looked it up in different languages. I can't find a word for it. But really what we've seen is this incredible difficulty and challenge for folks to be able to hold space in their head for both. And we have a pandemic and we have this really incredibly serious overdose crisis at the same time, and it's hard to hold space for folks. Sabine, if I'm talking too much, you have to tell me. I'll have to be careful around time-wise.
Yeah, it's
so
getting
sorry,
close.
yeah, is what you're saying. So when we sort of talk about the things that we just talked about, how this has actually impacted the numbers, and I just really want to put it out there that when I talk about numbers, when I talk about overdose deaths and what we're experiencing, I know very clearly that I am talking about people's brothers and sisters and aunties and uncles and sons and daughters, and I know that these folks are not just numbers. And so I just really want to honor the fact that the folks that when I speak of numbers, I know that I'm speaking of people that we love. And if you look at the numbers, I mean, we are seeing right now, you know, at the end of September, these numbers are till the end of September, and the new numbers for October will be out later on today, actually, later on tomorrow. We've lost over 12,000 or 1,200 people in British Columbia. And some of the statistics in the overdose crisis have remained sort of the same across the last 5 years. So we know that men are 5 times more likely to die than women. We know that overall, almost 2/3 of the folks that are dying in the overdose crisis are dying at home alone in private residences. We know that 71% are between the ages of 30 and 59, and that's from 2017 to 2019. There's a small shift in those numbers, but again, they're fairly consistent. We know that overdose continues to be the leading cause of unnatural death in Canada. And we also know that our Indigenous brothers and sisters are disproportionately affected by overdose deaths and events. And I think that that's something that's very important to talk about and to really understand. We know that in January and February, Fraser Health experienced a 91% increase in overdose fatalities compared to January and February. And we're seeing that sort of pattern continue. We had a small sort of reduction in the amount of overdose deaths in September. And we know that like August represented the highest number of illicit drug toxicity deaths ever in Fraser Health. We lost 60 people in August, and that's just in our region. So I'm not talking about BC, I'm talking just in our region. And I think it's really important for folks on the conference to really understand that like since 2016 in Chilliwack alone, we've lost 118 of our citizens to overdose. And I think that that's really important to really think about, and to really think about how that lands on our community and how it lands on our fabric of our social fabric. So, and I know that these numbers are hard, like it's hard to hear. And so I also think that it's really important to think about the things that we can do right now that can be helpful. And that really truly can be helpful. And there's 80 odd people on this conference, and all of us have the ability to have some sort of impact in the overdose crisis. And so one of the things that we can do, and we can do right now, is we can increase our referrals to drug checking services. So Chilliwack Public Health, you can get your drugs checked. Now there are some qualifiers around that. We don't have a fancy FTIR machine yet in the East. Maybe one day we will. But for now, we do still have some access to drug checking. If folks are familiar with the Lifeguard app, demonstrate how to connect to virtual options for witness consumption, like Lifeguard or Be Safe, or developing personal virtual plans. Like being able to have these conversations is really, really important. Signing up for our regional overdose alerts and radar alerts. So those are alerts that come from, the radar comes from Vancouver, and then you can sign up for Fraser Health specific overdose alerts. And we're in the midst of trying to figure out a better system for overdose alerts as well. Encourage folks to use it, overdose prevention services or safe consumption sites, which we don't currently have in Chilliwack. I'm aware of that. So, but we're working on it. Use the Take Home Naloxone site finder on the Toward the Heart website, so you can connect people with Take Home Naloxone if you're unfamiliar with this, with sites in your around us. I mean, you can certainly connect folks. Increase our focus on overdose conversations and safety planning, regardless of substance use, regardless of drug of choice, and regardless of folks' recovery status. None of that matters. Right now, we're in the midst of a very significant overdose crisis. So we should be talking universally to everybody about this. And we can also do other things like increasing access to pandemic prescribing. I know that some of the folks on the phone won't be able to do that, but certainly we can look at ongoing advocacy and sustained treatment beyond isolation periods, and looking at really just trying to help people connect to things that will be useful for them in the midst of substance use. And one of the other great easy things that you can do is consider becoming a harm reduction site. You can distribute Take Home Naloxone. You can distribute harm reduction supplies. Call me. These are things that we can sort out and work through. And I know I'm out of time, so I'm just going to share this last thing, because I think this work is really hard, and I know that a way it's really heavy on my heart, a lot. And so I said I wasn't going to get choked up, but I'll get choked up anyways, because that's just who I am, and it's okay to be vulnerable, because we understand that this work is very, very hard. And so, and I think it's really important to acknowledge that this work is hard. And sometimes it's so hard that it can be really tough to bear it. But I also think, like, to sort of end with that, in the midst of this, we need to make space for joy. Because quite frankly, if we don't, we won't be able to keep doing this. And we need people to do the work. So I just wanted to leave you with this poem, which I'll read out loud to you, because you probably won't be, if you're like me and you're old and you can't read things without good glasses on, then I'll just read you the poem. And I just wanted to end with this instead of ending only in sadness. So I think we need to hold space for sadness. We also need to hold space for joy. So no matter the pull toward brink, no matter the florid deep sleep awaits, there's a time for everything. Look, just this morning, a vulture nodded his red grizzled head at me, and I looked at him, admiring the sickle of his beak. Then the wind kicked up, and after arranging that good suit of feathers, he up and took off, just like that. And to boot, there are on this planet alone something like 2 million naturally occurring sweet things, some with names so generous as to kick the steel from my knees. Agave, persimmon, stickball, the purple okra I bought for $2 at the market. Think of that. The long night, the skeleton in the mirror, the man behind me on the bus taking notes. Yeah. But look, my niece is running through a field calling my name. My neighbor sings like an angel, and at the end of my block is a basketball court. I remember. My color's green. I'm spring. Thank you.
Thank you, Leanne. So does anyone have a quick question for Leanne before we move on? Can you stop sharing and then I can see?
Oh, yes.
Yeah, I just want to see if anyone's waving their hands or has if not, that's all. Oh, Brenda Boy. Oh no, clapping. Okay, that's a different hand symbol. Sorry. I didn't know about that one. Well, thank you, Leanne. We're going to move on to the next presentation. Dr. Amy Salmon, findings from the Fraser East Overdose Response Study. Are you able to share your screen, Amy?
Yes, I think so. Let's just see here.
All right, and from the beginning, please. All right, can everybody see that? Okay, I am so thankful that I got to follow Leanne. She's already told you everything that you need to know about the overdose crisis, and I can maybe just fill in a few blanks. So thanks, Leanne, for your words, and thanks, Sabine, for the invitation to be here today. I'm going to share a little bit with you about this study that we've been doing. My name's Amy Salmon. I work at the Center for Health Evaluation and Outcome Sciences, which is part of UBC and also Providence Healthcare. I'm presenting today on behalf of this magnificent group of people that I am so fortunate to be able to work with. And in particular, I'd like to recognize Marinelle Nisley, who is here today and has in so many ways been the heart and the soul and the driving force of this study in Chilliwack. And we have a lot of the good work that we've been able to do to thank her for that work. So the Fraser East Overdose Response Project is a study that that was initiated in early 2018. So we've been at this for a little while. This is a project that was really started not by myself, but by Jennifer Hawkins, Mike Sikora, Andrew Larder, and a good coalition of folks who came together between Fraser Health and the city of Chilliwack with the goal of really collecting the evidence that would be needed to identify practical strategies that would be likely to be effective in reducing or eliminating deaths due to unwitnessed overdose in the Fraser East region. So Leanne has already spoken very well to the importance of focusing on that population of folks who use alone and the risks that are associated with death due to overdose in those contexts. We've really been wanting to, in focusing this work, to look at the Fraser East region and identify, I think, some very place-based perspectives on why it is that people come to use alone, where the points of support might be, where those deaths due to an unwitnessed overdose can be prevented, and to identify solutions that will really work for the Fraser East region, including in the community of Chilliwack, that we are going beyond, at least in our intention, the focus of just simply taking interventions that have been developed in other places like the downtown east side of Vancouver and plopping those into communities like Chilliwack without a lot of thoughtful examination of what's most likely to be effective in these places. So we began our work with the focus in Chilliwack. We're now expanding that work to include surrounding communities, but still very much based in the Fraser East region. Knowing that time is short, I'm going to give just a very quick tour of some of the key findings that have come out of our qualitative work. I'll mention also, though, that we have a strong partnership with the BC Centre for Disease Control and the provincial overdose cohort team there. And what that allows us to do is look at some of the ideas that we generate through community consultation and that we learn from people when they tell us the stories of their experiences, and to see how that's playing out at a population level. So I'm not going to speak to that population level data today, but I'm happy to do so if people have questions. So what we were looking to do with this analysis was to really, as I said before, obtain a deeper understanding of the risk factors that contribute to people being hidden when they're using substances, and then the risks that come from using alone, and then unfortunately leading in many cases, as Leanne referred to as well, to people dying alone. What we're finding, I think, unsurprisingly to anybody in this virtual room and all of the work that you do, is that the reasons that people use alone are complex, and they often are result of a number of co-occurring, overlapping, and interlaced factors. So far, we have spoken to 22 people who have been using drugs during the time of the provincial health emergency in the Fraser East region. The majority of those folks have lived in Chilliwack. Of those folks that we've spoken to, just to give you a sense of who the people are that have participated so far, about 60% identify as Caucasian, 32% have identified as Indigenous. They range in age from 25 to 54 years, with a median age of 35. And while they're recruited to our study or invited to participate, specifically because they identify as using drugs alone in the Fraser East region, it's important for us to underscore here that only 18% of the people that we spoke to actually live alone. So when we ask people about why they're using alone, we found that their decisions are being driven by a number of factors. So the availability of drugs and personal funds that people use to buy them. Drugs are expensive, and people talked about risks to their personal safety and well-being that can come when they're using drugs in the context with other people where they might be forced to share them. And they're not able to. People talked about other risks to their personal safety and social scenarios surrounding drug use that drive their reasons for using alone. So for some people, talked about about concerns about how they behave when they use drugs and the damage that they feel could occur to their personal relationships with people that they love and care about if they're around other people when they're using. People also, as I mentioned, talked about other factors related to their personal safety, particularly so for women who are using. Feelings of shame were often a very big part of people's stories when they talked about why they use alone, and wanting to make sure that their substance use was hidden. Also, with this, feelings of shame come to people's very real understanding of risks that come to their personal relationships, to their reputations, to their housing, to their standing in the community and their ability to participate in family and community life that might come from having their substance use be made known in a more public way, particularly if they were accessing services that made them more visible. And for those whose substance use was located inside a pattern of addiction, issues related to their addiction and mental health were those that some people identified as being important, so that at some times in an addictive cycle, or when feeling very depressed or anxious, people might be more likely to use alone at those times than at others. Here are some examples of things that people had to share with us about this experience, kind of speaking to the points I've just made. So there's this idea of, that we have to recognize, like, in a real way, that drugs are expensive and cost money, and that for some people that fuels a decision to use alone. I think there's also this other important point that we can't just take people who use drugs alone in private residences to be one monolithic group who always makes the same decision. That in fact, there are a number of contextual factors that lead people to make a decision to use alone at some times or at another point. This statement that was shared with us from this individual, I think where they're talking about is everyone is using in solitary at some point or another, even when together in a group. And it's those times of being alone that can point to particular risks. And then, of course, we spoke just a few moments ago about that role of shame that I know is so well understood by everybody in this room. I'll just take a quick minute, knowing that time is short now, to tell you about a sub-study that we've done with a group of our interview participants. So as I mentioned, we've interviewed 22 people who've been using drugs in the Fraser East region, mostly in Chilliwack during the public health emergency. So since April 2016, of those that we've spoken with, 13 people identified themselves as having a history of incarceration. So we know already from the literature and from lived experience and from service provision that people who have a history of incarceration have been particularly at risk during this public health emergency for both fatal and non-fatal overdoses. So we wanted to speak more to people who have these histories about what their perceptions are about the relationship between their experience of incarceration and their risk. And again, I think not unsurprisingly, in speaking with a diverse group of folks, we received diverse understandings of what this relationship is. So for some individuals that we spoke to, they were very clear that being incarcerated increased their risk for overdose in some pretty tangible ways, particularly when OAT was not available. For others, they felt that their experiences of being incarcerated had a limited impact on their substance use or overdose patterns, that they didn't notice huge changes themselves, although most recognized that people who were incarcerated as a group are often more at risk. And then for some, people talked about their experience of incarceration being a time when they were able to address their addiction and get connected to services. So we see through those examples that when people are able to be connected well during vulnerable times, including while incarcerated and directly after their experience of incarceration, that risk can be reduced in those contexts. Just as I wrap up, I wanted to say a few words about the very important role of family and friends in relation to overdose prevention. We are hearing, and again, this is no surprise to anyone in this space, that very few supports exist in Fraser East and indeed across the country for family and friends and others whose loved ones are at risk for an overdose. What we did find, and I think as you can see in the statement from this individual here, is that when family and friends are engaged well and can reach out without judgment, without support, and when they have the support that those families need to be able to do this work with their loved ones well, that family and friends play an incredibly important role. So we're now turning at this time in our study to reach out and to conduct interviews with family, friends, and other loved ones of individuals who are at risk of an overdose, to try and understand a little bit more about what supports those individuals themselves could need, so that they can in turn support their family members well and reduce those overdose risks. And also so that we can, I think, you know, as Leanne was saying in her presentation, I think encourage all of us to look outwards and to be addressing this crisis from the perspective of a loving and supportive community, and not just individualizing this risk of overdose by making it only the responsibility of people who use drugs to maintain that safety. So as I wrap up, I just want to say thank you very much to all of the funders and supporters who have been part of this journey with us, including our partners, again, at Fraser Health and the City of Chilliwack, the Chilliwack Social Planning and Research Council for some really important funding that has supported our work. And I've also got my contact information here if anybody would like to follow up with questions or comments or curiosities. Thanks again.
That was fantastic, Amy. Thank you so much.
Thank you.
Does anyone have a question for Amy at this time? Or are we gonna go ahead and move on, which I think we could do. Amy's contact information will be up on our website as well, if anyone wants to connect directly. So our next presentation is Dr. Asim Grover and Brenda Poulton, the East Fraser Pain Collaborative, Substance Misuse Prevention. Are you able to share your screen there, Brenda?
Yeah, there we go. And I'll begin our presentation here. Okay. Well, first of all, thank you, Sabine, and the Chilliwack Healthier Community Group for including us in your morning. I'm Brenda Poulton, and I'm a clinical lead for pain in Fraser Health. And I have the pleasure of presenting today with Dr. Asim Grover, a family practitioner working in Hope in the Fraser Canyon, who also works in addiction and complex care. We both sit on the East Fraser Pain Collaborative, which was begun in Chilliwack by a group of very passionate physicians who saw the need for change in how pain care is delivered and the lack of resources, and quickly realized that to really have an impact, they needed to reach out to the surrounding communities. So now we've involved Abbotsford and Mission as well as part of a collaborative. And I'm here to tell you a little bit about the work we're doing collectively with many other healthcare providers, medical and regional leadership, and of course, patients, and how we feel it strongly intersects with those struggling with substance misuse or addiction. The crossover population of those at risk or struggling with substance use disorder and also have chronic pain is large. Estimates range widely, but as per the provincial pain strategy draft, it sits somewhere between 30 and 60% of those that have substance use disorder also have chronic pain. Additionally, as complex populations, they also frequently struggle with mental health issues or stressors. Adequately managing chronic pain is critical to treating addictions. And undertreated pain is frequently cited as one of the contributors to addiction and problematic substance use. And Dr. Grover is going to expand on this shortly. One tenet in the prevention of chronic pain is there needs to be easily accessible, ready, trauma-informed, culturally safe, and collaborative pain care for any patients, including those who are struggling with problematic substance misuse. And there's often a barrier for those struggling to actually get into pain care. Hence, where the Fraser Health Pain Strategy and specific to the East Fraser community and the East Fraser Pain Collaborative, we hope to positively impact pain care. So I'm going to quickly outline some of the activities that are going on with the East Fraser Pain Collaborative and highlight those that are on a preventative lens on the strategies that are being developed and implemented. And then Dr. Grover will expand on the direct impact of chronic pain and addiction. So we are have multiple partners. We have 4 working groups, and we work on 4 pillars of change. And I'm going to touch on all 4 of these pillars in our collaborative. The first one is patient education and public awareness. One of the main activities is building an organized, easily accessible patient roadmap that is web-based. It's going to sit on the Fraser Health Pain page. And it's a step-by-step self-care and wellness map with navigation supports and connections to resources, both community and online. And again, including mental health and addiction resources and links. At the Ruth and Naomi Clinic, or mission, I should say, in Chilliwack, we are starting a low barrier pain self-management program starting in January 2021 with some of the staff there and Fraser Health, and it's access programs for a marginalized population to beginning self-care management and introduction and connection to those resources. Additionally, at the Ruth and Naomi Clinic and the New Hope Clinic, we're going to be running a pilot, low barrier pilot for medical pain management services, and we hope that's in early January to February range. And again, with this group, the working group, we're looking at public awareness, connecting with community, doing presentations such as this, and working on public awareness campaigns around chronic pain. The second working group is the provider education, and we're developing and just about completed, again, a provider education portal Again, it's web-based, easy access to vetted pain education. So up-to-date education at various levels of knowledge access, and including looking very much at that biopsychosocial approach. We know that's very important in managing complex patient populations, including those with chronic pain. Good information on how to be involved in trauma-informed care, cultural safety, mental health and substance use resources, and looking at prescribing practices. So again, that's going to sit on the Fraser Health pain page, web page. Again, organizing local and community online resources and local resources in the community. So practitioners know who is involved in pain, who can they refer patients to, what programs are running, easily accessible so that this can be getting patients to where they need to be in a fast manner. And then again, building that community of practice and awareness of health care providers working in pain in the East Fraser. The third pillar is service provision. And again, this is a bigger picture look. It's identifying the gaps in pain services and resources in the East Fraser, and then looking to bridge those gaps. In the short term, what can we do to reorganize, organize, get people involved? And in the longer term, when funding is available, how we want to be ready to be able to improve resources in those communities. So again, some of the key focused areas include the beginnings of a transitional pain service. This is identifying people early on if they're at risk for developing chronic or persistent pain, prior to surgery, after a trauma, any type of injury, and including the complex population of those with substance misuse in this early service. Again, looking at marginalized population pain services, such as we're doing at the Ruth and Naomi Mission, and certainly that self-management program is a collaboration with Pain BC, and we are actively looking to expand that in the East Fraser for those that are interested in where they think that may help populations. And again, there's also an Indigenous and Aboriginal framework available as well. Then expansion of the services at the East Fraser Community Pain Hub. This hub is a small service currently. We're waiting for that to expand with funding, but is a multidisciplinary team that practitioners can refer their patients into. It is a self-management program, quite structured, and also as a case review. So again, that's open to anyone in East Fraser, and we're now doing that virtually. So it's literally quite open for anyone, regardless where you live in the East Fraser. Again, additionally, we have an evaluation working group that's looking at certainly evaluating the programs we're doing and measuring that impact. So very active group, lots on the go. That's just highlighting some of the things we think that line up with prevention as far as chronic pain, and also then misuse of substances as well. I'm going to turn it over at this point to Dr. Grover, and he's going to talk about action for prevention of substance misuse and addiction from his perspective.
I'll make it quick. Thanks, Brenda. So Brenda and I have been working with a fabulous team. I've been working hard in an attempt to move the needle on pain care, because we really feel that it can impact several significant public health outcomes for several people across Canada. And that, pertains to the mental health, the suicide rates, and eventually the impact on the number of opiate overdoses. So what we're identifying is that the relation of substance use and chronic pain has a much stronger relation than expected. And then after listening to the journey of several of our patients who have developed opioid use disorder, chronic pain seemed to be a common impetus that pushed them to this point. As we learn more about people living with addictions, we're understanding that the overwhelming percentage of people who were struggling with chronic pain prior to transitioning to trialing illicit opioids, right? So taking a patient with chronic pain that trials illicit opioids, these patients then meet criteria for opioid use disorder, and this is just the beginning. So once a patient is deemed with opioid use disorder, the barriers to receive treatment for his chronic pain can be quite significant and overlooked, and now has an entirely different treatment approach. And this can cause delays in specific treatments required to treat his acute on chronic pain. This slide right here that we'll have up right here is really, trying to work on identification of, identification is a key process. Now, this doesn't necessarily mean that they shouldn't get access to the same treatment options, but that these people need a more robust pain strategy plan. And that really encompasses the biopsychosocial components that we've talked about. Our goal is to really reverse the trajectory of patients with chronic pain heading towards opioid use disorder, because this is becoming more and more frequent. So here are some identifying factors that may need a more robust treatment plan, and then we can eventually reduce their likelihood of heading towards substance misuse and eventually opioid use disorder. So on the right, we have our non-modifiable, which is our ACE scores, family history, underlying mental health. And then on our left, we have the modifiable. And why I say this modifiable is this is where the healthcare provider can really impact change. So early access to treatment, a team approach, good screening tools, and good transitional care in the community, which Brenda already talked about, and optimal follow-ups and family, optimal follow-ups with a family provider. Next slide, Brenda. So, you know, with the Canadian Pain Task Force, what we learned is that the impetus which drove the creation of the Canadian Task Force in March 2019 had a lot to do with the opioid crisis. So they wanted to help the government of Canada understand the needs of people living with chronic pain. The task force wanted to recognize the importance of addressing pain prevention and management more broadly to help reverse that trajectory for our patients moving further along that spectrum. Some recent highlights that they talked about in the recent iteration is that efforts undertaken to respond to the overdose crisis have led to challenging unintended consequences. And the inability to access opiate medications or continue their medications had significant adjustments to lower the prescriptions, and sometimes against their will. That eventually led to additional barriers for people living with pain. Next slide. So with substance misuse and addiction, these patients are challenging and they're complex. And so it's, you know, our role to help find solutions to address their unmanaged pain. And this can be a key means for reducing first exposure to or reliance on opioids and preventing harms associated with substance use. So overcoming barriers, this has caused some people to obtain illicit drugs to self-manage their pain and putting them at serious risk. And our goal is less misuse, less chronic pain, and eventually less addictions, which will lead to less overdose. Next slide. So our long-term outcomes, you know, we have high hopes, and eventually what we would like is less demand for illicit supply. And this really stems down to the prevention of reducing those patients that have chronic pain going to the streets to try and elicit opiate supply, and then to work on reduction in patients who are struggling with addictions, and eventually that this will lead to quicker access because of less lineup or waiting times for facilities. I think it's important that, you know, that these patients have good trust and good rapport with their physicians and other allied healthcare professionals, because that will eventually get them help quicker. Okay, thank you guys.
Thank you very much. Is there any questions for us?
Hi, Brenda. So this is dealing with people who have, this is my read of it, is that people who have pain and managing that pain in order to prevent the long-term outcome of addiction. Is there anything in this report about, and I get all that, is there anything about safe supply involved in this, or those are two separate things as far as you guys are concerned?
So,
oh, go ahead.
No. When we talk about safe supply, right? Because if you're taking chronic pain patients, a lot of those patients have attachment to a family or a primary care provider. So when you're talking about potentially safe supply, they potentially have already used maybe some illicit supply already in the past and now have met criteria for opioid use disorder. So the challenging part is that that spectrum of them going towards opioid use disorder, we really want to get them back down the other reversal in that spectrum to really get the key components of why they've had chronic pain to begin with. Because a lot of the times when they're diagnosed with opioid use disorder, everything gets overlooked. There are key components that led to the acute on chronic episodes of pain, transition to opioid use disorder, and the management options sort of change. I know that didn't really answer the question, but it's involving two different sort of people.
And certainly some of the programs that we are involved in, such as the collaboration with Pain BC for making sense of pain, that's a low barrier, have high tolerance for if people are currently actively using. They have some norms within their groups that they work through together. Additionally, all of our pain hubs will take anyone that has current or active substance misuse, as long as they're ready for change and looking for ways to collaboratively start towards that change. We're happy to support them in every way to get there with our team. And again, as Dr. Grover said, it's very much that looking at that physical, mental, and emotional social wellness as a whole being. That's where we're going with this. So again, hopefully, Rod, we've answered some of your questions. Certainly, we need way more resources, way more dedicated to those that crossover population, and looking at ways to really reach out to, as Dr. Grover said, help to address some of those core issues that started them down perhaps on that path. And we know that chronic pain is one of them.
So I have a question. How does somebody become connected to the pilot?
The pilot that we're running for the low barrier program?
Yes, yes.
You can reach out to me if you're in Fraser Health. We have run this pilot. It was piloted down in the downtown east side, and we have run it out of the Aboriginal Wellness Center in Wally, and also we are currently running it in the Detox program in Surrey. And so we're just moving it out into the East Fraser, and happy to collaborate with anyone. There's a whole curriculum. We work with staff to help mentor them to be able to deliver this program. So yeah, so please reach out if you're interested.
I'm thinking though for a patient, like if there was, how would they become attached?
Oh, currently, well, the first program is going to open up at the Ruth and Naomi Mission, and there'll be some advertisement there, and they can reach out to the coordinator. When the information comes out on Friday, there will be a coordinator for our pain hub, and there's a email address there, or offline. I'm happy to give you that if you'd like it sooner.
Yeah,
Program's going to start third week in January.
Yeah, I think the information may be provided through the divisions also, maybe, Brenda, right?
Yeah.
And of course, if you send it to the coordinator at Chilliwack Healthier Community, we'll put it in the Friday mail out, and it'll reach over 900 local health and social service providers.
Okay, and we are looking to establish other groups in the early spring, et cetera. So if anyone thinks that may be a fit, you want to talk about a little bit more, very, very happy to supply that information.
Thank you.
Thank you so much, Brenda and Dr. Grover. Fantastic information. Moving on to our next presentation, Hunter Larocque. Now we're kind of pivoting onto behavioral addiction, one of them, to share his information. Hunter, can you share your screen?
Okay, so we are, like I said, changing a little bit to behavioral addiction. So a little bit of what I'm doing is we're changing it to more of a specific. So I'm going to talk about one addiction, that being porn addiction here. So I'm going to introduce myself. So I'm Hunter. I'm a practicum student from UFB. I'm doing my practicum at the Chilliwack Youth Health Center. I'm actually a CRIM student. And I'm being a CRIM student and the CYHC focusing on youth counseling. I was able to take an opportunity to do a movement and a program instead of the counseling portion of it. So the program I'm actually doing is called Horton Hears a Who, and it's a child-proofing porn movement that we started up, I believe, early this year, and I just got onto it as of September, and I'll be passing the reins on as of January, so I won't be here too much longer. But I'm a little bit about like what Horton Hears Who is. A little slow here, just a sec. Okay, so Horton Hears a Who is a movement aiming towards protecting young people from the effects of viewing porn, which may cause multiple different reactions. So as studies show, like a lot of individuals professionals believe that porn is not able to be addictive trait, but a lot of the professionals as well do. So it's kind of like a controversial issue that is going on as we speak. So one of the focus that we're doing is to hold porn websites liable for the content they put on, as well as create more liability to ensure that verification of age to access porn is above 18. So more and more youth are accessing porn on a regular occurrence, and this correlates to many different issues such as irregular expectation of sexual intercourse, improper education, and more violent acts towards typically towards female. As of September 30th of this year, the movement has been assisted from Senator Julie Melville-Deschênes. I'm sorry if I completely massacred that name. She's an independent senator from, I believe, Ontario. She proposed a bill to the Senate called Protecting Young Persons from Exposure to Pornography. So this bill restricts youth accessibility to porn websites by ensuring such websites implement a verification of age of their users. Since then, it's currently actually on the second reading of November 3rd of this month. And we're just kind of waiting for it to be passed at this moment. So I was a little about like what Horton Hears of Who is. So porn addiction is classified under behavioral addiction, as talked about a little bit earlier. It is a compulsion to viewing any form of pornography, from being at websites to magazines to pornographic images of any sort. So with porn being so easily accessible through the internet, websites such as like Pornhub, and which is actually Canadian made off in Montreal. Porn addiction is a form of operant conditioning because you can gain a reward by viewing porn that actually makes you want to keep gaining that reward in the future. So you keep going back and you keep going back and keep going back towards it, which is a occurrence of a form of addiction. So the signs here, keep in mind that like everybody's signs are a little bit different. It's all independent for each individual. So each person can have different signs, but some of the signs that may be showing towards someone that might have an addiction are failure to resist viewing porn at any time, having strong urges for other stimulations such as drugs, increase secrecy in relationships, and a loss of jobs due to chunks of time lost from viewing or inappropriate viewing while at work. So that being said, there are a lot of individuals that are viewing porn while working ahead. What are the causes of porn addiction? So the underlying mental health issues such as using porn to escape psychological distress. So many of the reasons for the addictive patterns of viewing porn have been correlated to trauma of youth and throughout their childhood. And that's kind of very prevalent in many different addictions as well as mental disorders. So being able to correlate those two together is very good step in the right direction to understanding what porn addiction is. When viewing porn, MRIs, they did a small study on it because it hasn't been fully studied overall. Yeah, that's one of our hopes that we're hoping to achieve here. Show that, so when MRI is done on an individual that is viewing porn, it actually activates the same part of the brain that substance addictions actually influence. So that's another good correlation between the two. So relationship problems are another cause that maybe due to porn addiction. And sorry, there I got a little tongue-tied. I'm not the greatest public speaker here, but so an outlet for sexual dissatisfaction and unhealthy cultural norms, as well as unrealistic expectations of sexual activities, are another sign. And biological causes can actually change the brain chemistry when viewing porn. So we'll talk about a little bit of the effects on youth here. So the effects on youth is increased levels of sexual activity at a younger age. It increases more dominant submissive sexual activities that they may have been viewed on porn websites, and increase in multiple sexual partners, sometimes during a single event, and thus increasing the risk of transmitting sexual diseases. Increase in negative expectations towards opposite genders, and it is 6 times more likely to become violent and aggressive during sex after viewing an aggressive porn video. So those are very, can't think of the word there, so I apologize, but why would it be harmful for youth to watch porn, and why we're hoping this movement goes towards helping the Senate to pass this bill. The brain, as you know, is a sensitive but very powerful organ. And the brain is easily motivated by perceived rewards. And the pathway for this reward in the brain is the ventral tegmental area, the nucleus accumbens, and the prefrontal cortex. At youth, it's at its very most sensitive state, so they're at the highest risk for having porn addiction kind of like be more prevalent. So porn stimulates the brain, which releases dopamine and increases the chance of impulsivity for addiction, as well as increased activity for other substances to be used. And sexual driven dopamine causes the brain to change and become needy towards sex, and many times relationships will fail because the sexual activity they're experiencing is not equivalent to what they're viewing on websites that they're able to see. So I talked about the bills being passed at the moment, and Gordon Here's Who has been kind of a big movement on helping this kind of go through the Senate here. So a way that everyone that is willing to help that kind of sees it as an issue, I can leave the link towards the petition that's able to be signed in a couple of seconds. That will kind of spread the word and show the Senate that people are aware of the issues here. Overall, thank you. Sorry about it being a little bit muddled. Not the greatest presenter there. So
No, you did a great job, Hunter, and thank you for bringing. CHC has an addictions task team. We always try to remember that even though we're in an overdose crisis, and when we're talking about addictions, we're talking about substances, but there are many, many other addictions out there, a huge spectrum of behavioral addictions, one of which is porn. And the work that the committee and yourself are doing to get youth protected from porn is incredibly important. So thank you so much for sharing. Does anyone have a quick question at all for Hunter? So seeing no questions, I on our agenda, Ron, you're up next with Breaking Barriers, but I've got a message from Andrea, who is our 6.2 presentation. She needs to leave early, well, not early, but on time, and we're running a little bit long. She's wondering if she can go before you. Would that be all right, Ron?
Sure. When will I be on? When can I be off? Because I also have other commitments. So but she can go ahead. But what is your time? How do you read the time? When will I be done?
I think that Andrea, we're talking 5-6 minutes in total. And then right after that, Ron, would that work?
Sure. Yeah.
Well, then I'll just move on to Andrea Dykesworn, if I've pronounced your last name correctly. So if you can just introduce your project, and do you need me to do the link or can you?
You know what? I think I'll be okay. I have been having some fun internet problems and have gotten booted off a couple times already this morning, but I think we got it sorted now. So yeah, hi everybody. My name is Andrea, and I see a few familiar faces and a few familiar names on in this group. I work with United Way as a community engagement specialist. And since the pandemic, I've been supervising a team of the 8 staff who are engaged with pandemic emergency response. And so they are seeing a lot of needs coming from the community and doing a lot of work to address and to connect people with supports. And a lot of what we've seen is related to mental health, including the effects of the overdose crisis. But I'm here to talk about a bit of a more creative initiative in the area of prevention. And I don't think I have to explain to anyone here on this call about the importance of prevention in this type of work. So last fall, I had the opportunity of being introduced to Dr. Mark Gradanis, who is an ER physician here in Chilliwack. I think probably a number of you know him and know his passion for preventative work. He's on the front lines and he's seen a constant stream of overdose victims, including young people. And when I chatted with him, he said, you know, I want to see these kids out in the forest. I want to see them out somewhere other than in the ER. And Dr. Mark is a director with the Chilliwack Park Society. And some of you have probably visited Luquam Park or the Chilliwack Community Forest before. And the Chilliwack Park Society essentially built all of the trails in those 2 areas. And they've done a lot of work with maintenance. And when Mark and I spoke, we were talking about getting more youth out, young people out to the trails to learn how to build, to learn how to maintain the trails, and then also to learn how to mountain bike. And we talked about how this could be such a great opportunity to work in overdose prevention, giving kids another outlet for their highs, getting their adrenaline hits from flying down a mountain on a bike rather than through drugs. So over the past year, we've been working specifically on building connections with some of the local Indigenous communities, including Stalo Service Agency and some of the local bands. And thanks to these relationships, we've been able to bring dozens of youth out into the forest already. And it's been incredible. We even have been able to hire a couple youth, including one Indigenous young man who's taking a leadership role in doing peer mentorship. So lots and lots of exciting stuff. And I wanted to just share a really brief story about this past summer after a trail building day that we had organized with Stalo Nation. One of Stalo's staff sent me a message, and he said on the drive home, after the youth he was working with had spent a couple of hours moving dirt and rock and tree stumps and then riding the same trails that he had cleared, this young man turned to him and he said, "In all of my life, I've never, ever had fun like that before." And we had put him to work for hours. And I was just told this young man couldn't wipe the smile off of his face. It was incredible. United Way has tracked a lot of stats, and we know that 1 in 10 kids in the Lower Mainland and up to 1 in 7 in the Fraser Valley do not think there's an adult that cares about them. And the pandemic's increasing isolation, and along with that, anxiety and depression. I'm also working as a clinician, an intern at the Chilliwack Youth Health Center, and I see anxiety and depression levels going through the roof. Lots of people with suicidal ideation. And it's no wonder that young people are turning to drugs as an escape, but I'm really excited about this initiative because it's taking a strength-based approach. It's looking at what we have in our community, the assets that we already have here, both resources, natural resources, and people, and working on the level of prevention. So I could talk for a long time about this initiative, but what I would prefer to do is actually show you a little video clip, because then you can see some of the smiles from the youth themselves. So it's just a couple minutes and we'll see if I can find it here, and hopefully this works.
it has increased existing barriers for youth. It's increased isolation. It's increased the mental stress that they're feeling, and it's decreased their access to social networks and resources. We know that substance abuse, overdose, there's a lot of crisis in our communities surrounding that.
Dr. Mark works as an ER physician at the Chilliwack Hospital, and he sees youth who are in the middle of this overdose crisis. One of the strengths Dr. Mark identified in the community was the vast network of trails and the opportunity to build more trails. Here in the Chilliwack Community Forest, and today what's happening is we have our youth trail crew, and they're out building and maintaining mountain bike trails and hiking trails. And so these youth are having the opportunity to get out on the land, socialize, but in a safe way.
Being a trail building really interesting. Some days we're doing just simple brush work around the old trail that no one wants to do. Some days we're making a whole new trail like today. I love trail building because it gives me a good workout and it helps me to connect to the outdoors.
These young people are out on the trails 5 days a week. They're building, fixing, maintaining, and being such great ambassadors for nature and for the outdoors. And they're also mentoring other youth, such as the Indigenous youth that are coming out today to learn how to mountain bike.
I like mountain biking because it gives me the sense of adrenaline, of high speed and high control. The feeling of the wind going against my face I can't live without it.
For youth, the hope is that you can create safety where uncertainty exists, and you can create access, and you can really keep them connected to the community in this time of social and physical isolation.
This is a community-driven initiative. It came from the residents here in the community and residents who wanted to care for each other. And so really, for me and for United Way to be able to come alongside them and support the work that they were already wanting to do, but maybe needed a few more tools, it feels really, really satisfying.
It's beautiful out here, and I get to see beautiful sights every day, especially with friends and colleagues that I worked hard with and built a good bond with. It's awesome. I love it.
That's just a little clip of some of the smiling faces. We had a full-time crew out this summer that we were able to hire, partly through the overdose prevention grant that we received, and then partly, sorry about that. YouTube decided to keep playing in the background. Yeah, anyways, the overdose prevention grant that we received really helped us to be able to build some foundation for this work. And then we got a Canada Summer Jobs grant to hire a couple of the youth. And this is growing too. We were able to find some funding to hire somebody else to take it a step forward. And Lloyd, who you saw in the video, is taking a big leadership role. He is bringing out, we had a crew from Traverse out yesterday, and he was involved in doing some of the teaching around safety orientation and how to clear the trails. So yeah, it's pretty exciting. And I don't want to take too much time, but if anyone has questions, I'll just drop my contact information in the chat and you're welcome to reach out to me.
Fantastic, Andrea. Thank you so much. Really appreciate it. I think just so that we can move forward with Ron, we're going to go straight to Ron and the Breaking Barriers project. And thank you so much, Andrea. Ron, do you want to go ahead and introduce yourself and share your screen?
Can you see my screen?
Not yet.
See it now?
Not yet.
Oh, so what do I do? Share screen. There we go. Right?
Perfect.
Okay, so good afternoon. My name is Ron van Wyk. For those that don't know me, I worked for 20 years in Abbotsford in the social service sector. I lived in that time in Abbotsford, in Chilliwack, and now I have sort of semi-retired and was pulled into this project by the city of Chilliwack and Fraser Health called Breaking Barriers. So I suppose the impetus for this project goes back to the fact that, you know, people who are homeless, and then people who are homeless are marginalized. And then if you add on to that, perhaps people also living with addictions and or mental health, then the marginalization just becomes bigger. So in response to that and recognizing that, the city of Chilliwack and Fraser Health obtained some funding to work on a project that that has two components, which is one an employment component, and one component is to reduce stigma. So the idea would be to look at ways that through employment perhaps you can create greater community integration, but also contribute to stigma reduction. So that's by way of introduction. So the project implementation team consists of Mike Sikora, Jennifer Hawkins, and I think the idea was conceived by Jennifer to a large extent to create this project. Liz Miller from Fraser Health, Sabine from Chilliwack Healthier Community, and myself, who has been contracted by the city of Chilliwack to work with the team to roll out this project. So I don't have any findings to report as yet, because we are still in the process of obtaining information and data. But the idea was today to just make you aware of this project. Some of you already are aware of this and have been part of it through either me interviewing you or you helping to identify for us and linking us with people who've lived and living experience to be part of this project. So as I've said, it has two components: the employment initiative and the stigma reduction initiative. We've identified as a project team guiding principles that will guide the project as we implement it, and that is the involvement of people who've lived and living experience is paramount. It's very important. And that it is a community collaborative approach. So you will see when we look at the project advisory committee, it consists of representatives from a range of organizations present and working in the city of Chilliwack. Then obviously whatever we do should contribute to stigma reduction and should also reduce harm. And it needs to be evidence-based. So we're looking at what are emerging practices associated with employment options and initiatives for people who are homeless, and also looking at best practices. And then it needs to be culturally sensitive, the way we go about and interact with people, and also our interaction and rolling out the project should be trauma-informed. So stakeholder consultation, there you can see, you know, who we have interacted with. We have, to date, we have had about 78 people with lived and living experiences who have completed surveys for the project in which we ask questions and get their input. We are now in the process of doing more in-depth qualitative interviews with people who've lived and living experience. So we have had access to some shelter guests and staff that has facilitated for us interaction with people that have lived and living experiences. Then Leanne from Fraser Harm Reduction has been also interviewed, and we learned from her experience and understanding and the knowledge. And the staff at various organizations listed there: Stolo Service Agency, Métis organizations, Downtown Business Improvement, SAPCO, Community Futures, and residents and RCMP, Clifton Security, etc., etc. So those are the stakeholders that we have consulted with so far. Some of them we are still in process. You can also see then we are also focusing on projects in other jurisdictions and other areas who already have done something like this or are in the process of rolling out or implementing a employment program or initiative for people who live homeless, or who are homeless. So we've looked at the one in Abbotsford called BEEP, Business Engagement Ambassador Project, and you can see the list there. I'm not going to read through all of it. So again, some of them we have already spoken to and obtained their input. Others are still in the process of being contacted. And then the work plan and timeline. So we started working on this in May. It was also delayed, the implementation, by COVID. But you can see we are now in the process of doing project and program visits. That was the initial idea, but because of COVID, we cannot do in-person visits, so we do virtual visits now. And stakeholder consultation is still continuing. The stigma reduction events that were planned as part of this project, which would have piggybacked on the New Meetings Meal program, and the work that Sabine and others have been doing in the past, have been put on hold because of COVID. And so what we are talking to the funder to see whether we can park some of the funds for that particular component of the project. And hopefully when COVID is in a different phase in the new year or in the spring, then we can go back to those components and do some work around further stigma reduction events in Chilliwack. So then December and January will be taken up by putting together a project draft report or a design of how a project or projects or what it could look like to implement employment options for people who are homeless and or living with addictions and or mental health. And then hopefully we can finalize the project design by February, report back to the city, and then it would be the next phase, which is not be part of this project, would be then to look at funding to implement employment initiatives or programs for people. And then the last slide just contains the names of the project advisory committee members. I hope I haven't missed anybody there. If I have, my apologies. So yeah, that's just by way of telling you what this project is about and where we are. And we are looking forward to put together a concept design that is informed by peers, by people who've lived in living experience, and also by people who have had the opportunity to already done this and have learned some lessons that we can benefit from. So yeah, thank you. And if there are any questions, I can quickly entertain some of that. But thank you to those that have participated in the project to date, and for those that still will participate down the road. And many of you are sitting in this virtual meeting. Thank you.
Thank you, Ron. Anybody have any questions? Ron, perhaps you can hit stop share. I'll just scroll through all the people. All right, why don't we go ahead and move on to our next very quick presentation. Diane, I'll bring your slide up right now. There it is. Go ahead, Diane.
Thank you, everyone, and to all the other presenters in terms of their amazing information. I just wanted to spend a very limited amount of time, because I know we need to move on with things, in terms of discussing the Community Action Initiative, which is part of a provincially funded approach across the province to communities in terms of the overdose crisis. So what we did was a group of us got together and presented to them last year a sort of two-pronged approach to what we wanted to see happen in Chilliwack. One was to develop a comprehensive strategy for Chilliwack, and the other was to get our hands dirty, roll up our sleeves, and fund some projects. So we got $75,000, and so we did do those two things. And just to let everybody know, we've applied for another $75,000. The approach that the group wanted to take was to continue to fund projects of a very diverse nature. And so we are going to be moving ahead with that. So I'll very quickly just go over these projects that we funded. I do note that the United Way did a great job of presenting what it is they worked on in terms of the resources that were provided through these provincial funds, and that other organizations like PCRS are on the call as well, and they certainly can pipe in as well to their project. So just very quickly, the initiatives that we provided support for in this last year. The Stroller Service Agency, we funded a women's conference on substance use and harm reduction. And one of the things that we're very proud of here with projects is how diverse they are and how they really tap different parts of the overdose area in terms of what it is we wanted to look at addressing. So Jody Wilson-Raybould was in there, as well as training around substance use and harm reduction. The Pearl Life Renewal Society did training on, formal training on called Ending the Game, which was on women exiting sex work, including naloxone training for community staff and volunteers. I think some 40 women benefited from that. The United Way Lower Mainland project that we talked about. And again, this is very, it's unique in that it emphasizes works particularly with youth, as well as on the issue of connection and attachment to recreation and environmental initiatives. So very groundbreaking in terms of what we saw. Pacific Community Resources Society, this focus was and is continuing on the issue of stigma reduction, particularly also around issues like men or people in trades who are overly represented. And I don't know, Kim, I think, sorry to put you on the spot, but if you're still around, if you want to maybe make a couple of comments on what happened there. No, maybe she's had to go. As well, we had as mentioned, a couple of Indigenous projects, and Squaw First Nation did an initiative, an elder text program, but also more broad than that. People with lived experience, naloxone training, and other initiatives were undertaken by the funding that was provided. And then finally, the Chilliwack Youth Health Center, and that was to work with youth mental health and youth peer work in terms of connection with young people in terms of the overdose crisis. So I think with the limited time, I won't get into too much more detail, but if you have any questions, just to let you know, that Chilliwack has been approved for another $75,000. So we're just waiting to hear from that committee at the province in terms of our proposal. And then we hope to either extend projects or fund new projects in the upcoming year. So thank you, everybody, and to all those people who also delivered the amazing projects that occurred.
Thank you, Diane. So just segueing into our last presentation is one of the projects that were funded by these micro grants. And I'm just going to pass it over to Jade Black and Christine Waitman to say a few words and then hit their video.
Hi all, thanks Sabine. I'm just going to share our screen. Okay, not that. So we went into collaboration with the Division of Family Practice, Stallo, and then Dr. Mark assisted on this project as well. And the mini documentary, as we like to call it, was produced by Levi Allen, who is owner and founder of Left Coast Media. And then we got some money from PCRS, as Diane just mentioned. So we're gonna just show the video.
Hey, how are you? You know what, I'm gonna phone you back on the narrow.
I'll just jump in. There is a way, if you want the audio to play through the speakers, to reshare the video, and there is a checkbox when you're sharing it about the audio control.
I'm sorry, I missed that. Somebody was talking.
Yeah, there's no volume right now, Jade.
So Jade, if you stop sharing and then reshare, and there is an option in the sharing box to click, it's sort of on the bottom left, I believe, with audio controls. So we'll hear through our speakers.
Thank you.
You're welcome.
Here. Okay, my apologies. Let's try this again. Can everybody see the screen?
Yes.
Okay.
Having an overdose crisis right here and now in our own community.
I was like a soccer mom. I would do my bit in the morning, get up and just power through my day.
I was a first aid person in my community. I've had people die in my arms.
The picture you have of someone overdosing is someone on a street with a needle in their arm hunched over. That's the picture jumps to your mind of what an overdose looks like, which we know is not the majority of the cases.
The majority of people who are dying from overdose are dying in their homes, they're dying alone.
It's tragic because it's so preventable. Like, no one has to die from this.
Life got out of control, but I didn't want the ministry to find out and take my kids. I didn't want a lot of my peers to find out and judge me. I didn't want my family to find out and think that I was failing. I wasn't really taught coping skills at home. You know, it's a story that people hear often. What's unique, I think, about my story is where I'm at now and how I got here. And how I got here is with care and support from people who believe that we're not just drug addicts.
It is quite heart-wrenching, you know, to get these people to a point of talking to me, and just at that point they die. And you know, I say, why couldn't have been here last week? You know, why could all those different things cross your mind.
When I was 30-something, you didn't ask for help. Women didn't ask for help. You're at home raising your kids. You got through stuff. And I really didn't actually see the issue with it until I couldn't afford it anymore. And then it was a big issue.
Around disclosing to loved ones, family members, brothers, sisters, people down. There's such a diversity in people who use. That's the core of the issue, is that people will experience judgment, and then from there could be shamed, or it could trigger shame within them.
I guess one story that they may be telling themselves is that I need to do this on my own. I need to be self-sufficient. I need to be self-reliant. And I cannot show anyone that I'm vulnerable and cannot handle this.
Our people, these are my aunties, my uncles, my sisters, my brothers. These are my people in my community that are experiencing overdose at a disproportionate rate.
In a traditional household, there's no shame in asking for help. There should only be pride in the fact that somebody asked for help. We should honor that because they're doing something beautiful.
Because I've been that person that didn't have anywhere to go. Somebody walking by and throwing a shoe at me. That only adds to the shame. It's just not how we're supposed to treat people. I often tell people this is our community and we are only as strong as our most vulnerable citizen here, right? And that is the absolute truth.
It's highly likely that people in your life that you're related to, these could be your brothers, your sisters, your cousins, your parents even, are at risk of dying from overdose.
There are many patients who were afraid to begin with to come talk to their family doctor about their use of drugs. And then all of a sudden, the fact that maybe there's COVID-19 in the doctor's office might have been a little bit extra barrier for them to not come when they might have otherwise. My understanding is another thing that's changed is the drug supply itself. People selling drugs, dealers, distributors may have had to use more dangerous substitutes.
Well, there is a poison supply out there, and it's not just limited to fentanyl. It's in the amphetamines, it's in the barbiturates, it's horrible.
Are people that have jobs, that have their own homes, that are still maintaining their family relationships, maybe using some drugs in order to, as a stimulant. The demands of a job where the hours are long, the work is very hard, they may need something to boost their energy, so they may be using a stimulant. And it's possible with that stimulant supply, such as amphetamine or crystal meth, may have been poisoned or contaminated with fentanyl at some point in the process, so that someone who is not used to, their bodies are not used to taking opioids, thinks that they're taking stimulant. It may be tainted with opioids, and that might be what's killing them. The idea is then, if we had, say, another common stimulant, which is caffeine, every 1,000th or 10,000th cup was poisoned with something that was killing somebody who was drinking it just to get their morning boost, we wouldn't be calling that an overdose crisis. We'd be saying there's something poisoning the coffee that you're drinking.
Found myself 45 years old, still going back to the same space, still dealing drugs downtown Abbotsford and pregnant. Something had to give, something had to change. I'm generally a very hopeful person. The first time in my life I'd lost hope. I figured I'd keep ending up back here. This is where I'm meant to be, I guess. My daughter walked into the space where I was living and was like, "Mom, what are you doing? What are you going to do with this baby?" And adoption was the plan. And she just said, this is what you're good at. Just have your baby. And it wasn't even really the words that it was just the fact that she was there, and in that it was a very critical moment for me, and to have someone that actually cared to show up and let me know that I was able to move forward, that I was able to change what was going on in my life at that moment, and I took it and ran with it.
In traditional society, the person who cleans up the sweat lodge, tidies it all up, is very important. That might be the apprentice to be able to do that in the future. Well, we need to expand that to all things. Teachers and people who build homes, or fathers who stay home while a mother goes to work. We need to value all people.
I think the best thing that ever happened to me was making a choice, or realizing that I had a choice. Drug addict is not who I am. It's just somewhere I've been.
Overdose crisis has brought addiction to the top of mind of so many people. And that's really promising, because the more we talk about it, and the more we help with accurate information, the more more we can clearly see what the real problem is and begin to tackle it.
There is somewhere to go, that there is somewhere you can make that change or that choice for yourself.
And we go and we blame. Yes, you're pointing and blaming all those, but what about these other 3 fingers pointing back at you? What have you done? You got 3 fingers pointing at you, so what are you doing? What you gonna do today? What you gonna do tomorrow?
So some small achievable things that people can do if they're choosing to use drugs are, first off and most importantly, are to have conversations with your loved ones, whether it's your friends, your family, parents, brothers, sisters, or if that's not safe and you need to use by yourself, there's the Lifeguard app that you can download on your phone, and you check in to say that you're going to use, and after a certain amount of time you check in to say, yes, I'm alive and safe. There's the Narcan kits that are being given out in different community centers and as well available from the pharmacies, so that if you are using with friends, that they can have that available. We all need to stay open to learning, and I'm learning, you're learning, and we can do that together. And I think it's a good opportunity to connect with loved ones to save lives.
Thank you for that. I'll put a link in the chat box because I know it was a little bit glitchy there towards the beginning, but encourage you to just forward the link and share the video with your networks, those who haven't seen it. And yeah, if anyone has any questions, maybe we have time to answer one, and if not, we can wrap up. I know we're getting pretty close to the end of the session.
Thank you, Jade and Christy. That was just it's such an excellent video and such a great way to end a really amazing event. I'm